Hello, I'm Dr. Saloni Shirke. I'm a PGY1 resident at Mercy Hospital, Fort Smith. Today, I will be presenting a case that highlights the safety and efficacy of rituximab in the treatment of p-ANCA positive microscopic polyangitis. Posi-immune necrotizing and crescenteric glomerulonephritis rapidly progresses to end-stage renal disease within days to months. It is associated with ANCA-positive vasculitis, including granulomatosis with polyangitis and microscopic polyangitis. Our patient is a 28-year-old female with a history of postpartum cardiomyopathy. She was recently diagnosed with rapidly progressive glomerulonephritis secondary to p-ANCA positive microscopic polyangitis. She presented to the emergency department with high-grade fevers, chills, and a frontal headache. The patient had been hospitalized 1 month prior for a petechial rash, symptomatic anemia, and severe acute kidney injury. Her p-ANCA titers tested positive. A CT-guided renal biopsy was subsequently performed. Histopathological findings are shown in figures A to D, revealing interstitial fibrosis and tubular atrophy affecting 80% of the cortex, along with necrosis featuring cellular and fibrocellular crescent formation consistent with posi-immune necrotizing and crescenteric glomerulonephritis. The patient was treated with pulse dose steroids and rituximab, leading to clinical improvement. She was then transitioned to tapering doses of prednisone. Dapsone was prescribed for pneumocystis prophylaxis. On this admission, she was found to have severe neutropenia, pancytopenia, and septic shock secondary to E. coli bacteremia while on immunosuppressive therapy. As a result, rituximab and dapsone were discontinued. In addition to filgrastim, she was treated with broad-spectrum antibiotics, which were later tailored to microbial susceptibilities. During the hospitalization, her renal function deteriorated, necessitating hemodialysis. Her hypoxia worsened, requiring emergent intubation. A CT scan of the chest is shown in figure F. As you can see, there are patchy ground glass opacities and small consolidations throughout the perihilar regions of the upper and lower lobes, bilaterally consistent with alveolar hemorrhage. These findings were later confirmed with bronchoscopy. The patient was treated with high-dose methylprednisolone, emergent plasmapheresis, and intravenous IVIG. After stabilization, she was discharged with a tapering dose of prednisone and arrangements for peritoneal dialysis. The treatment of ANCA-associated vasculitis with RPGN is a two-step approach, the induction phase and the maintenance phase. The former involves the use of glucocorticoids along with cyclophosphamide or rituximab. Current guidelines recommend initiating with high-dose steroids followed by a tapering regimen. However, there is no consensus on the most optimal tapering dose or the duration of glucocorticoid therapy. Cyclophosphamide, when combined with steroids, has demonstrated more than 90% efficacy. However, it is associated with significant toxicity. In 2011, the FDA approved rituximab as an alternative to cyclophosphamide. It is the preferred choice in cases of relapsing disease, refractory disease, or when cyclophosphamide is contraindicated. If a patient does not respond adequately to one induction agent, it is recommended to switch to the alternative agent. Furthermore, pneumocystis prophylaxis is indicated in patients receiving anti-CD20 monoclonal antibodies or a glucocorticoid equivalent greater than 20 milligrams of prednisolone daily for 1 month or longer. However, both rituximab and dapsone are associated with febrile neutropenia through distinct mechanisms. Severe febrile neutropenia can lead to life-threatening complications and increased morbidity. Only a few studies have demonstrated the safety and efficacy of combined rituximab and dapsone in the treatment of ANCA-associated vasculitis. Compared to other first-line agents for ANCA-associated vasculitis, rituximab is associated with lower incidences of PJP pneumonia. Therefore, further research in this area may contribute to reducing adverse events and improved clinical outcomes. Our references are shown below. Thank you for listening.